Well, it's really my great honor to have Dr. David and Dr. Davey Alleman here in our YouTube channel. I mean, we've been friends now for almost 2 years. I actually spent some time with them initially in Utah. Then I decided to take their mastership program, which is, I mean, it's really kind of changed the way that I view things and that I do things in my practice. And I thought that it was going to be very important to have you guys over in our channel and kind of give a little bit of your perspective. Talk about deep margin elevation, and that is something that is being people are doing or are trying to get it done fairly frequently in today's dental practice. And it is very technique sensitive. It has this little particularities that are need to be addressed, and that need to be kind of seen before you even get into a patient. So first and foremost, before we start with the topic, if you can just a little bit about yourself, so that people, I know they know you, but just know a little bit more about yourself, I would really appreciate that.
Well, we've been teaching this since 2003. And so 2003 is now 22 years. So for 22 years, we've been training hundreds of dentists in these techniques that we call biomimetic dentistry. And it started with just my frustration of traditional dentistry. Traditional dentistry relies a lot of crown lengthening surgery, a lot of root canals to retain posts and do crowns. All of that has a potential to fail in a very bad way. And so advanced adhesive dentistry, which we call biomimetic dentistry, was pioneered by myself, Simone Della Peri, Pascal Magnier. Those were the main three people that really are known for biomimetic dentistry. But now Davey and I have been teaching together for 13 years, I think, before Davey went to dental school. And now we have a system that prevents root canals, prevents crowns, and saves the teeth for decades instead of years.
Yeah, so I'm Davey Alleman. I've been practicing since 2015. I was in the Army for 4 years after graduating from Roseman University of Health Sciences. I was stationed in South Korea and in Arizona, and I've been in private practice for the last 5 years and been teaching with my dad. And our only goal is to make the doctors we train as good as they possibly can.
Yep. We want
And,
teeth to last a long, long time.
right, and one of the things that I do also want to mention, the reason, David and Dr. Davey, the reason why I chose to follow your steps and to kind of go into your mastership, honestly, was because of the clinical aspect. I feel that when you are in clinical dentistry like we are, I've been doing this for 31 years. You really appreciate when somebody that's teaching you or that's guiding you or mentoring you also is in that battlefield, seeing patients every day, because every patient is different, every deep margin is different, every isolation is going to be different. There is no cookie cutter type of technique that is going to work on everybody. So it does make a big difference for those out there that are listening to this webinar. It does make a big difference when you're choosing your mentor, that your mentor is active clinically and that knows the different avenues on how to make this work in a private practice setting. So with that, with no further ado, let's go ahead and get started with the topic.
All right, so the topic today is deep margin elevation techniques for long-term clinical success. This is an aspect that we teach in lesson 4 of the 6 lessons approach for biomimetic dentistry. And I loved what you said, Mario, that in order for you to really trust your mentor, they have to be in the trenches. And there's no trench quite like deep margin elevation.
That's right. It can take 2 minutes or it can take 20 minutes, but you don't know until you get there what you're really dealing with for isolation. But once you master isolation and then master the steps of what we call the 6 lessons approach to biomedical dentistry, it becomes predictable.
And so questions that might arise is, if you're completely new to a deep margin elevation, where is the best place to start? Now, deep margin elevation is it's not taught very effectively in dental school. Even some of the schools that embrace deep margin elevation ended up saying it was just too hard.
Well, the problem is we have to look at deep margin elevation as a separate procedure. In traditional dentistry, it would be analogous to crown lengthening surgery. Now, that's a procedure that is separate from anything you would do to the tooth, but this procedure of DEM, if you think of it as a separate procedure, once you do it, you basically can stop and reschedule the patient if it's too difficult, or you can reschedule your patient. But the idea is you need to think of deep margin elevation not as part of your biomimetic final product, but as the foundation for what's called the biobase.
Now, every dentist has procedures that they really gravitate towards and stuff that they try and avoid. And for me, I knew very early on that surgery was not my answer. Anytime I'm extracting a tooth, I get too amped up, I get shaky, and it's just a complete disaster. I always feel like, am I going too aggressive or am I going not aggressive enough? And it's just this Goldilocks that I could never find just the right amount of blood in the operating field for me to feel comfortable. And for me, no blood is the way
to go.
This
is the answer.
And so when you're talking about deep margin elevation, it really relies on your isolation. And so this is my mantra. If I can isolate the tooth, then I am going to restore it. If I can't isolate it, then perhaps I send it to a periodontist for crown lengthening surgery, or perhaps the tooth is just hopeless. But many of the teeth that I fix, if you just spend that extra 5 or 10 minutes focusing on your isolation, you will be surprised at the teeth that you can restore and have predictable results.
So to prevent contamination of blood, saliva, and moisture, this is what we do.
You need to emphasize your isolation. So adhesive dentistry requires excellent isolation. I want you to imagine this tooth walks into your practice. Patient was told they need a root canal and a crown and some crown lengthening surgery. Now, if this comes into a dental school, nobody would refute any of those ideas. The only problem was when I tested for vitality, it tested fairly normal to cold. And when I took a look at the tooth clinically, it looked like a total disaster. As I look at the bone level, it's relatively high. We've got some serious challenges. And to top matters off, this was a good friend that I played high school golf with, and he traveled an hour to have me take a look at his tooth. Last patient of the day, I see it. I say, man, we can't wait 2 or 3 weeks to try and save this tooth. We need to do this today. So my assistant's just shaking her head and just thinking, Davey, you're already slow. It's Friday afternoon. I've got places to be. And this is what you're going to do? And so we went through the process. We isolated the tooth. Every step went better than I expected. And when I completed the deep margin elevation, I went to lunch with my friend, or early dinner. And I said, look, earlier this week, I shot a 68 on the golf course. That's 4 under par. That's pretty good golf for an amateur golfer. He was impressed. And I said, what I just did on your tooth was more impressive than what I did on the golf course.
That's right.
Because when I saw this post-op x-ray, I said, you know what, Davey, you did something that most dentists can't do. And that's what I live for. I live for this idea that perhaps I am better than the dentist that I went to dental school with, or that I served alongside in the at some of my other clinics. You know, I want to be the best at what I can do, and I love it.
Well, we should also say that from a biologic standpoint, a tooth with a pulp acts very differently than a tooth that doesn't have a pulp. The hydration of the pulp gives the tooth flexibility and what's called toughness, and it decreases the brittleness of a tooth. And this can make sure that the tooth has as long a function as possible.
Now, after I said that to my friend, you know, in the back of my mind, I said, well, this still might need a root canal. I post this on my Instagram.
Sure.
Guess what? Everybody said that thing's going to blow up this weekend.
Yeah, that's what they say.
And well, 3 years later,
Still fine.
the tooth is still vital. Patient is extremely happy that he traveled down to get this tooth fixed.
Mhm.
And I feel very confident that even if this tooth ended up losing vitality, this tooth will not be lost.
And everyone
And for
listening
me,
to
and
this,
I'm sorry to interrupt there, but just as a student right now, I'm gonna behave as a student. Just for me to, even if the tooth ends up in a root canal, you still save the tooth. For me,
Exactly.
that's something that we have to understand. A lot of these teeth, even before thinking about a deep margin elevation or a root canal that maintains the tooth in the mouth, today these teeth are being extracted just because of the fact that they're hard to restore. Not
correct.
not any other, not, there's no other reason than just because it's hard to restore. I don't know if you guys agree with me on that.
Yep,
Absolutely. I mean,
absolutely.
if we go back to this picture right here, if you understand what I've done in order to get my matrix in place and maintain the isolation, that is a systematic approach. And in order for you to have the consistency you need to understand the system to ensure that your isolation and your bonding field isn't getting contaminated. Because if the tooth is properly sealed and there's enough healthy tissue, then the tooth is going to heal even in a tooth that is highly infected like this tooth was. But I would say that maybe 50% of the doctors would have said, maybe we should think about extraction and implant. Because if we're doing crown lengthening surgery, endo, and a crown, you're probably in the ballpark of $3,000,
Mhm.
and an
Exactly.
implant's around five.
Right.
So let's focus really on isolation. Now, there's a myriad of ways to isolate a field, from rubber dam, isovac, isolite, cotton roll, and as long as you maintain perfect isolation for about 2 or 3 minutes of any procedure, you can have success.
The isolation that I used when I was first starting to do biomedical dentistry was a split dam technique. It wasn't as sophisticated as this, but it saves time the more sophisticated you get. And I would encourage everyone to try to get as much training in rubber dam isolation as possible.
Now, in my first 6 months after graduating dental school, I was in South Korea. We had access to an isolite, and that's what I used for my isolation, and that worked, very well. But in certain instances, I would find that my mirror would butt up against the block as I was trying to maneuver my handpiece and restore the tooth, and it kind of became frustrating. And eventually I said, you know what? If I have a rubber dam, I can kind of move my mirror any way I want to. And so I said, you know what? I'm going to recommit myself to using rubber dam on every possible tooth.
The
Now,
other thing, Davey, that I want to say, being a faculty at the Dental College of Georgia for 9 years, we're in the student clinic. We had ISOVAC and ISOLite. I can tell you one thing, and I want to ask you this if you agree with me or not. But the difficulty becomes when you have a deep margin, there's always a little bit of inflammation, there's bleeding, and there's curricular fluid. How do you get the ISOVAC in that curricular in that crevice? How do you get it in there?
exactly. And in those cases, what you're going to have to do is some kind of electrosurge procedure or laser procedure. And then oftentimes you'll say, well, I'm still getting a little bit of heme, so I'm going to rub some viscostat. And what happens with viscostat when it contaminates dentin, all of a sudden you'll lose your bond.
Exactly.
And so if you can have really good isolation,
You don't have to worry about
you don't have to worry about it. Now, my dad did a lot of split dams, and sometimes he would have to, use electrosurge and really wedge aggressively in order to prevent any.
and a lot of cord. You'll
Cord.
notice we won't use cord in this technique.
But once you get better at rubber dam, you'll find that you have a clear operating field. This will be the best way to prevent blood or salivary contamination. And there is some evidence that it is the best way to have, less humid or moisture content in your bonding field. How
Mhm.
clinically relevant is a little bit of breath? I don't know, but
Right.
um, when we think about the rubber dam, I always think you gotta have something that pushes the dam further apically and move it away from my margin. And there isn't a better material than PTFE or Teflon tape because you can pack it, and when your burr just lightly touches it, doesn't rip it out like it
Right.
does with
Cord.
cord, and it doesn't tear like it does if you hit your dam. And so everybody that's tried placing Teflon has been frustrated. We're going to teach you
The secret.
the secret. And the secret is to dry the tooth and wet your instrument. Teflon is attracted to static electricity. So if there's a little bit more static electricity on the tooth, then as you're packing, it won't just slip up every time that you push it.
The one thing that I tell you that I do is that I actually roll my Teflon. I do exactly, the way you do it. I learned it from you, putting that little water, which I just want everybody to know that works beautifully. Um, so and it does do exactly what you're saying, and that's really the main reason, because you know that the burr hits the rubber dam, it's just gonna go everywhere, and it'll make the patient, jump out of the chair, and you also jump out of the chair if that happens. So the Teflon is crucial for these deeper margins.
Yep.
Now, not only is it important for the isolation, but it becomes even more important as you are doing a matrix within a matrix. And the best material to do a margin elevation as you approach crestal bone was first introduced to me by a doctor that my dad trained years ago, Dr. Bob Paxton, who said, "You know what? There's just nothing quite like a copper band." And he said that while I was in dental school. And I said, "I don't even know what that."
What a copper band is.
That-
Mario knows what it is. That's an old technique.
Yeah.
Copper band impression, single tooth impression.
And so here you can see I've got a copper that's resting on top of the Teflon that I've packed, and then a circular matrix that is stabilizing it. And so when we do a deep margin elevation, like my dad said, this is a separate procedure, and it prevents the need for crown lengthening surgery. And if you're like me and you're bad at surgery, you live for doing deep margin elevations.
But for the patient, you've got 6 weeks that you're saving of healing time, and you're saving in our area about $1,000 for the surgery. I mean, the advantages to the patient to be able to do this in one procedure, and even if they have to come back for the impression for the enamel replacement for the onlay, it's still a very time efficient and a money saver for the patient. So to develop these skills really gives you a competitive advantage over other even biomimetic dentists that don't have these skills.
And the other thing is that I just recently, just last week, completed a case. I had to go into deep margins on two teeth, 14 and 15, twice. First time, the tissue was, I mean, the caries were so deep, the tissue was so inflamed that I was not even with Teflon, with good rubber dam, I just wasn't able to maintain my margins clean. So what I did is I restored them anyway, send the patient home, have him use an interproximal toothbrush, give him good temporaries, allow the tissue to get better, have him come back. Second time around, I removed the previous restorations, did everything again, but now no bleeding and really good control. I don't know if that's ever happened to you, Davey.
Actually,
I
two
mean,
months ago, 2 months ago, I had a patient come in. Davey was working in another operatory, and I did not have the skills that Davey had, or the patients. And I had the same situation. I had some bleeding contamination, but even with these bonding systems we have, you can, even with bleeding, you can get enough of a seal that the tooth will stay in a healing position for several months. And then I have the patient come back, reschedule, and that will be the situation. But you have to have the ability to see with magnification what's happening. And if you have contamination, then you say my isolation wasn't good enough. What are my options? Better isolation or crown lengthening surgery and healing? But all of these things, a biomimetic dentist is seeing these things and knows that a deep margin elevation is the alternative to crown lengthening surgery. But if you can't get your isolation, you still can seal a tooth with contamination to an extent that the healing of the gum tissue will happen.
You're right. And that's exactly what happened to me just a couple of weeks ago. And I brought the patient back 10 days later, redid the whole thing, and was now able, with better health, better periodontal health, was able to isolate better, pack my Teflon tape, and go ahead and elevate those margins.
Yep.
Now, it doesn't matter where you practice, whether you practice in Florida like Mario, Utah like us, or if you practice in Australia, Canada, Africa, Ecuador,
Uzbekistan.
Europe. Guess what? You are dealing with deep decay, deep boxes, and deep cracks.
There's no patient, there's no practice that is really fixing teeth on real patients that doesn't deal with subgingival decay every day or every week. And the deep margin elevations that are only 1 millimeter subgingival, the isolation's easier. But still, you need to understand, once you pass the CEJ, you are restoring root dentin. That's different than coronal dentin. And that has to be part of your treatment approach.
And so I'm going to echo the quote that my dad had with the conversation with one of his colleagues and friends, where he was just saying, look, the life of the dentist is not incipient. If the life of the dentist was incipient, like we were taught on typodonts, guess what? You wouldn't ever need to do a deep margin elevation.
In the 6 lessons approach, we have a lesson 2, what's called a diagnosis of structural compromise or structural integrity. In other words, if you can't understand the difference between a 3 millimeter box in a class 2, or a 4 millimeter, or a 5 millimeter, or a 6 millimeter, or an 8 millimeter box, then you need to have more education and training to understand that you have to understand your restorations are not going to be surrounded by enamel 100% of the time.
We call these problems the 3D problems of deep boxes, deep cracks, and deep decay. Every dentist is facing challenges with either a previous restoration that is difficult to isolate. They've gone through a multiple of bands trying to capture the margin, or perhaps they have a crack and they don't know what they should do with it. And so they just say, well, I'm just going to pretend like it doesn't exist so I can isolate it and seal it. Or in other instances where dentists definitely can't ignore the problem, such as deep decay, all of a sudden they're back to square one of now I've got a deep box.
Right.
But as deep margin elevation has become more accepted in the literature, remember there was a lot of resistance. And this early paper that talked about doing some deep margin elevation techniques still relied back on a traditional surgical approach as soon as we got to deeper levels. And so if they said, well, if it's only 1 or 1.5 millimeters subgingival, yeah, then we can isolate with the rubber dam and do an adhesive procedure. But as soon as we get past that with a grade 2 or a grade 3, then we have to go back and do some kind of surgical crown lengthening.
Yeah.
Now, that surgical crown lengthening can mean 8 weeks of healing time for the patient.
Right.
Now, if you're bad at surgery and the last thing you want to do is send it to the periodontist and then see the patient back in 10 weeks, you're going to say, well, everything's going to be now a grade 1 because my isolation is going to be significant and proper, so I can still seal and elevate these margins so they're now equigingival or slightly.
But what drove me to crown lengthening, surgery, I should say, to deep margin elevation was the problem of how do you isolate for endodontic treatment? In other words, if you have a subgingival margin and you're going to be squirting bleach and your dam cannot hold the bleach, then you're going to have a hard time with the endo. I became an expert in endodontics, trained by Steve Buchanan, my classmate at University Pacific. But in a situation where I was doing a molar endo subgingivally, I said, I need to restore this so I can get my rubber dam sufficient containment of the bleach. I fortunately, in my office, had a system that worked very well in these subgingival areas. It was called Automatrix by Dentsply. And Automatrix by Dentsply doesn't rely on a Toffelmeyer, which can distort the band, but actually was able to, and it had a thick enough band that I could push on it. And so the very first deep margin elevation I did was so I could do an endodontic treatment. And so I adhesively raised the box with the rubber dam and the auto matrix containing the bleach. But then once I prepared the endodontic treatment, I'd already restored the box with composite to allow me to do the endo. And so I'm looking at this bonded box and I'm going, I've been doing this adhesive dentistry for 3 years. I've made progress every year in materials and techniques. I knew a gold standard bonding system. I knew what an incremental technique did for stress reduction. All of a sudden, I knew what air abrasion did for removal of the smear layer. All of a sudden, I had confidence after 3 years of adhesive dentistry in normal boxes that were maybe 1 millimeter, 2 millimeters deep. But now I was down 4 millimeters subgingival and I had restored this box. And I'm going, traditional prosthodontics says now I need to get back to the sound tooth structure so that I can put a crown on it. In 1998, I was stopping doing crowns at all. My last crown was in 1999. But in 1998, I'm saying, now this endodontic, the dogma is you got to have full coverage here. But I believe if I covered the cusps with an onlay, an overlay, I would say, I believe that I had the ability to stabilize this tooth. I mean, this is thinking that I'm doing chairside as I'm doing this tooth. Am I going to put a crown on this tooth? Because if I'm going to get a ferrule 4 millimeters subgingival, I'm going to have to do crown lengthening surgery.
Exactly.
And then I said, I believe this bond is stable, and I'm just going to do an onlay. And that's what I did in 1998. Nobody else had ever published this. I didn't learn this from Didier Dici. When I showed this case to Pascal Magne, in 2005, he said, nobody's published this yet. And I said, I know, I wanted to get five-year success. And now I was in 2005 when I had the first conversation face-to-face with Pascal. He said, nobody's published that. I know. I said, I think we should. Anyway, that's part of the history. But somebody has to do it first. And you have to have the right techniques, the right materials, but you also have to have a little courage to be able to say, I believe that this is the way it's going to be in the future. And so I can't take, I didn't publish first. Dici published in 1998, the same year first. There wasn't a big publication, but now we have dozens of publications on deep margin elevation. It's not in any way controversial, but it does take these skills.
Now, one thing that I want to mention before we continue is that and this is also kind of like a question to you guys, for both of you. But I normally, what I do today is I'm actually, if I have a tooth that I know as a fact that needs a root canal, it's necrotic, it's not responsive to cold, and I'm gonna need a root canal, and it has a deep margin. What I'm doing today is I'm actually restoring the deep margin, because what I have found is that many endodontists, when I refer them, because I don't do any endo, when I refer them the patient, they come back telling me this tooth is unrestorable just because it has a deep margin and it's really hard for them or impossible for them to isolate correctly. So what I'm doing is I'm actually restoring the tooth, restoring that margin, so that when it goes to them, they're ready to put their clamp. They know that they can seal. They can seal their rubber dam isolation and move forward with the root canal.
Yeah, you
So I
set
don't
the
know if you've
endodontist,
encountered that.
you set your endodontist up for success. And some of my biggest frustrations in the Army was I would have teeth that were either necrotic, needing a retreatment, or were hyperemic and irreversible pulpitis. And I would do a deep margin elevation, send it to the endodontist, and he would say, this tooth is non-restorable. I'm like, what the heck? I've just spent 2 hours doing the deep margin elevation. This is restorable.
Right.
But when you fall back on this idea of biologic width and this idea that you need 3 millimeters between your restorative margin and the alveolar crest, some endodontists that have a very pros heavy training
Traditional, yeah.
always feel like in order for you to not violate biologic width, you have to have some kind of surgical approach. And unfortunately, that always leads to healing time.
Yeah, the concept that comes from pros perio, perio-pros training, like John Coy's, Frank Spear, the dogma was biologic with violation was the ability of the biologic attachment to the tooth material was incompatible. It couldn't happen. There was going to be inflammation. Now we know that's false. We know that it's a myth, but it's a dogma that is still taught in perio-pros. The truth of the matter is, any inflammation of a restoration is based on a biofilm underneath the crown or underneath the filling. In other words, if you can't seal on a nanometer level your material to the tooth structure, you're going to have a bacterial film of 100 to 200 microns, and that will cause the inflammation. That's the truth.
And now we're not saying that a surgical approach is not doesn't have a place. If a doctor or a dentist really has a strong relationship or is very good surgically, you can always do a crown lengthening procedure and still do great biomimetic dentistry, and that's what this book showed.
2016, Bottichiari trained University of Geneva. His only option was crown lengthening surgery. He's in a practice with a periodontist in Italy, and they do 2,000 cases, and they do crown lengthening on all of them. Well, that's one approach. But if you have the ability to avoid that, again, there's benefits to the patient and to the practice to do it this way.
Now,
the thing is that he's got a unique situation that not every single one of us have, right?
In-house periodontist.
Exactly.
Yeah, if your best friend's a periodontist and he's right next to you, you throw them a bone every once in a while, right?
Right.
The other thing is that a book like this, which is really a landmark book, I mean, this book should be in every dental school, but it would say, in these situations where you're deep or subgingival, you have to have composite. So the composite inlay onlay, that's the title of the book. That's the only way you can get a match of the modulus of elasticity. And again, this is the topic of this lecture, but the sophistication and the evolution of biomimetic dentistry is personal for me. It's personal for Bottichiari. He found his way with surgery. I found my way without surgery, and then Davey's perfected the way to do it even in these most extreme class 3 diagnosis of subject.
And before we go into the materials, I just want to make sure that all our listeners know that in our YouTube channel, we have 2 videos, rubber dam isolation, the basic one, and we have advanced rubber dam isolation where we go into depth with the techniques and even how to modify clamps in order for you to, be able to isolate even the more complex case. And I also know that Dr. David in his YouTube channel has a series on complex rubber dam isolation also. So it's important that you kind of, figure out, go into these different YouTube channels and get the information that you need if you are not yet at the level where you think you need to be in order for you to be able to isolate cases like the one that Davey is sharing with us today.
Yeah, so the book by Stefano Bottichiari, his preferred method for doing his enamel replacement was a composite. And there's a lot of advantages using composite. Other doctors will have a tendency to move towards a stiffer material such as Emax. Now, it's important to know that a deep margin elevation shouldn't have something so stiff in the root. And so if your preferred enamel replacement is Emax or gold or something stiffer, you really need to understand that the tooth has a progressive flexibility, that different parts of the tooth have different stiffnesses as you go apical to coronal. And when we have a mismatch in stiffnesses, this will often create a bond fatigue under function. So we don't do deep margin elevation with a glass ionomer, which is too brittle and the bonds are too weak. And we also don't place Emax deep onto root dentin or deep dentin.
So Emax would be considered an enamel or a coronal replacement of missing tooth structure, but composite is the only material that can really match this modulus of elasticity as shown in this important paper published by Asiello in 2007.
Yeah, this paper showed that when we restored with a high modulus material, that there was a lot of stress on that was being transferred to the wall. And if the tooth is not under function, that may not be clinically relevant. But as we are chewing on a restoration, or your patient's chewing on a restoration, you really want to have some kind of progression. So even if it's just a 0.5 millimeter of flowable, that will often cushion some of that higher modulus ceramic that can be used for an inlay or an onlay.
We kind of use the analogy like shock absorbers. You wouldn't want to have a car without shock absorbers.
So in 1998, when Didier Dici did introduce the concept of deep margin elevation, he mentions that the tooth has progressive flexibility, and the composites that were being popularized back in the mid to late 90s, they were getting a modulus of elasticity right around 10 gigapascals.
Yep.
And this also allowed for maximization of tooth structure and also hard tissue. In other words, this was a defect-driven design to restore these structurally compromised teeth. And the main advantage is once you relocate your margin supragingival, you're going to have better impressions.
Easy.
And your deliveries are going to be more predictable.
When I first invented this technique, all of a sudden, I was saving a ton of money on impression materials because I wasn't have to repack cord and take 2, 3 impressions on these deep margins. And all of a sudden I'm going, I like that. This impression material stuff is expensive.
So here on this tooth that is right up against crestal bone, I've got my isolation. I'm packing my Teflon, and I'm really pushing the Teflon
hard.
I'm pushing this to separate PDL fibers and create space for this stiffer insert, which is a cut copper matrix. And I'm using a hemostat and my finger to really push until I get past the margin. Now, the best thing about copper is it doesn't distort apically, but it also has a high burnishability around a corner or a convexity or a concavity.
Another advantage of copper is that when you air abrade it, you can still bond to it without having it bond to the stainless steel bands, which will scratch and easily make a removal of the band very difficult. Copper doesn't have that problem.
So once my copper is stabilized between the dam and the tooth, then I will take a circular band. This is the Real Matrix by Garrison Deep Margin Elevation Band. It's pre-cut, so it's below the height of contour. And then we will tighten that in place.
And so placing the stainless steel for stabilization, because when you're doing clinical dentistry, it's easy for an instrument to get someplace and all of a sudden you knock the copper out.
Yeah.
But to replace it or to move it again, the matrix band, the stainless steel, just makes it easy. So you're not trying to tighten this up. You're just putting it enough that if the copper moves a little bit from a mirror bumping it or a handpiece bumping it, then all of a sudden you can just
or your micro brush.
Or your micro brush can do it. Yeah,
Right.
It's easy to stabilize that.
Yeah, I'm not stabilizing this with wedges because wedges will sometimes push a band up over your margin and coronal.
Right.
But here you can see these two deep margin elevations.
Deep.
Both were restored with composite inlays, and
3 years old now.
I think they're
4 years old now. That's right. Yeah, when Davey showed me this case 4 years ago, I go, this is one we're going to put in our lectures because this is a great one.
Now, back in 1998, when my dad was first doing a deep margin elevation, there wasn't a name for it at that time. And so he called it raising the box. And he said, it takes a lot of courage to be the first doing something, because when an endodontist or another dentist may see this work, what are they going to do?
They have no idea what's going on. And so you have to warn the patient. If another dentist sees this, don't let them do anything. Don't let them touch it, because if they don't understand it, they won't be able to appreciate what's going on.
Now, in order for a deep margin elevation to be successful, you need to make sure that you don't have a gap a gap that is so small that it doesn't show up on a X-ray. And so, because if we have a gap that is 100 or 200 microns um, in total thickness, you can start seeing those biologic width problems. But when we control for our contamination and really understand C factor stresses, then the idea of biologic width and the associated inflammation becomes a dogma or a myth, like these authors concluded back in 2014.
Yeah. And so this is a group of German dentists. And again, Dici did his first deep margin elevation without talking to Alleman. Alleman did his first deep margin elevation without talking to Dici. Simone Della Peri, the same. These guys out of Germany, they're all seeing this adhesive dentistry as a way to deal with this. But to get the published literature, again, 1998 to 2014, that's 16 years. But when they say this is now the dogma of biologic width being thrown away, because once you do this and you have the ability to stay bonded, you don't have the biofilm under the restoration and you don't have gingival margin inflammation.
So doctors that we've trained, they should see a hierarchy of bondability and understand that there is a certain level of caries that is left in order to preserve pulp vitality. And as we do our deep margin elevation, how we layer our composite is really aimed at decoupling or creating a separation for a period of time of the slow maturing bonds from the faster maturing bonds. So we don't jump from this image to this with 1 or 2 increments, but rather we might use 3 or 4 layers in order to maintain that seal that is approaching crestal.
And that technique was pioneered by Simone Della Peri. 2002, he published his classic paper on how to do that.
So if you don't understand that deep margin elevation is highly associated with the problems of polymerization stress and C factor stress within a cavity preparation, you are going to have inconsistencies.
Now let me ask you a good question, because this sequence of photos, go back one, Davey. These sequence of photos, just go one forward. These sequence of photos, there you go, right there, is crucial. And my question to you is, after you do your deep margin elevation and you bring the patient back for delivery, is your isolation easier?
Oh, it's so much easier. I mean, it's like
crucial.
there will be days where when you're doing the bio base or that first appointment, and you're fighting with your rubber dam and your clamp, and then you finally get it perfect. Maybe you sent it to the endodontist, and at the time of delivery or to finish your bio base before taking a scan or impression, you're like, that tooth wasn't that hard. Or the endodontist isolates it, and he doesn't realize that in order for him to just put some kind of W3 clamp on a molar, you had to use an anterior clamp and get really creative. But as the literature has progressed over the last 20 years, and they followed along these deep margin elevations that really were challenging not only periodontal literature, but also prosthodontic literature, they found that you would get a long junctional epithelial attachment to these well-sealed and well-polished deep margin elevations. Yep. In other words, there was few or no signs of clinical inflammation, because if you look at this instance, you have complete control of your margin. You are controlling your adhesive. If you're just trying to bond a gold crown that is subgingival with, glass ionomer or some kind of resin modified glass ionomer or resin cement, guess what? You're guessing, and you're just hoping on the X-ray that, that zirconia looks sealed.
Right.
I mean, it's a little bit of history, but I'm old and I'm the only one that can remember that, but maybe Mario can. Pete Dawson had a big reputation in Florida where you practice.
Yes.
But he made the observation because he had had some failures on crown cementations. He said this and taught this. He said, if you had to take an impression to get your preparation impressed for the lab, if you had to pack cord for that impression, then you must pack cord for your cementation, or else you will just be guessing, and often you will get tissue or contamination, and that will cause a problem with that seal, even a mechanical seal in the old days. But the whole idea is once you are at the level of the gingiva, the impressions never fail, and your cementation is never a problem with your gingiva because it's out of the way.
Exactly.
And so this was taught back in 2006 at USC with under the guidance of Pascal Monnier. And even though it's been in the school for over a decade, there was a lot of pushback on
and
deep
now,
margin
and
elevation.
now 2 decades later, it's not being taught in any consistent way at USC. Pascal's moved on. He's been out of the university for 3 years, basically because of the pushback that they felt like they couldn't train dental students to do this. Well, maybe a 1 millimeter is different than an 8 millimeter subgingival. Yeah. And so the skill level is different, but the concept has to be part of the science if you're talking about scientific evaluation and published results on adhesive dentistry.
These two papers that showed survival rates of deep margin elevation out of uh, Groningen in Holland showed that 96% survival rate after 12 years. This other paper, I don't know exactly where it's from. This just came out this past year by Pradea, showed that from 10 to 23 years, they only saw less than a millimeter of total bone loss in these deep margin elevations. And so it's really confirming that it's all seal dependent. And so when we do a deep margin elevation, we should use materials that mimic dentin and are layered appropriately. There is a key opinion leader that has a prosthodontic background that says you should do a deep margin elevation with some kind of resin cement like Unisem. Unfortunately, if you look at the literature, it's one of the worst in terms of creating a strong seal and under function. That's just going to chip and wash away.
Yeah, I mean,
Well, what happens today, Davey, is that you have all these bulk fill materials, and we're trying to make dentistry easier. And what we all have to understand is that good dentistry is not easier. High
right.
quality dentistry, high or advanced adhesive dentistry is not easy. It's predictable. But in order for it to be predictable, there's a sequence of steps, and you can't be jumping from one step to another. So,
Exactly.
but the idea, the way that we're practicing dentistry today, one dentist seeing, three patients at the same time, 30 minutes for each patient, you really don't have the time if you're going to try to do high quality adhesive dentistry like the one that, the ones that we're trying to do. But and I know that this takes time. You just gotta, you have to make sure that your practice is set in a different way so that when you are trying to do these procedures, you have enough time. You're financially, you're getting rewarded for your time and for your expertise. This is just a different way of seeing everyday dentistry, and the solution for this is not bulk fill, is not trying to simplify it, because again, it clinically it will fail.
We just had when we train doctors like yourself, Mario, we have a WhatsApp group that we maintain with the hundreds of doctors that we've trained. And we just had a string this morning of a doctor that we trained in 2008. In 2008, he started, and then he came back last year to get a refresher. And he said his biggest challenge was to charge enough money to justify the extra time it takes to do these procedures. But he said, as soon as I started doing it, I made a little more money. But the most important thing is that the patients, they trusted me, and they know that if I'm charging them more money, 30% or even 50% more, he says it's less than a crown.
Exactly.
If my crown is $1,600 and I charge them $1,100 for a restoration or 1,200, that's a win. But we're preventing the failure of the crown and the implant, which is going to be $5,000. I don't know what it'll be, in 5 years. But the idea is that the patients, when they know that you have advanced training and you have qualifications to do something that nobody else can do, then they're coming to you because they want better.
Exactly.
Now, when we were in Turkey 2 years ago giving a lecture for a big academic conference, the doctor that introduced my dad, she flew in from Istanbul. She simply said, "Thank you, Dr. Alleman," she was referring to my dad, "for making our lives more difficult." Now,
She was smiling. It was a joke. Half of the Turkish dentists didn't get it. She was speaking in English, but the English speaking audience, it was about 600 people in the lecture, they were laughing. But the idea is that if something is more difficult, then you can either do it or not do it.
but if you understand why you're doing something, you will fight the urge to simplify.
Right.
Because when you understand what creates success, particularly with adhesive dentistry, you understand that the stresses of polymerization go to one of three areas. They go either to the hybrid layer, to residual tooth structure, or within the composite itself. And so if you're placing a rib-on fiber and you understand what's happening with the molecular movement of the composite below and the composite above, then this starts to make sense on why there is less leakage when we put fiber on an axial wall on a deep defect.
And this is a big breakthrough, started in 2006 with Samabeli, a close partner of ours who teaches 6 lessons in Turkey with their partner an endodontist from Holland. But they're teaching these principles because they're based on science. But placing fiber on the axial wall, this is your best way to relieve the stress in these areas.
Now, one of the 3D problems with deep margin elevation is when you're dealing with deep decay, and understanding why you would do an indirect pulp cap instead of a direct pulp cap, and understanding how each of these layers of sound tooth structure, of enamel, superficial dentin, deep dentin, and then also inner caries and outer caries, and how they're related to not only bond potential, but also the time it takes for the bond to fully maximize. We call this the hierarchy of bondability. So when we're graphing these theoretical bond potentials, we see the enamel bonds relatively quickly. It maximizes within its first 1 to 3 minutes before plateauing, but dentin is a slow maturing bond. It takes time for it to reach its maximization and that plateauing effect. So if you're competing enamel bonds with dentin early, dentin will lose. But if you allow dentin enough time, then it can supersede the bond to enamel.
This is a very complex concept based on years of research by myself. But once you understand this decoupling with time, that you separate these different levels of bondability, which are directly related to how much hydroxyapatite is in the surface. Enamel, dentin, deep dentin, inner caries, outer caries, all have different amounts of hydroxyapatite, and that is the reason why some bond quickly and some take more time to establish a hybrid layer. And so we call this analysis C factor, configuration factor, as part of lesson 2 and lesson 4 analysis. But once you understand that the ratio of bonded to unbonded surfaces gives you a predictability of how much stress is going to be transmitted to your hybrid layer, then you can understand science that comes out in this paper in 2004 gave us the ability to see in a 4x4x4 preparation. Now that's all coronal dentin, but some of that dentin is deep, close to the pulp chamber. In a 4x4x4 preparation, how you layer your composite can mean the difference between 11 megapascal bond strength, 15 megapascal bond strength, 19, but 31 only comes with thin horizontal layers. And this confirmed the approach that Simone Della Peri introduced in 2002. So it's like stacking plates. You want thin layer upon thin layer upon thin layer. Every time you put a thin layer on, it takes a little bit of time. And by the time you're connecting the deep dentin to the enamel, it takes about 4 minutes. 5 minutes is better. 30 minutes with the deep margin elevation, that will happen every time. And all of a sudden, you have the ability to allow the weaker bonds or the more difficult bonds to be established enough time to compete successfully. So overlaying composite shrinkage moves towards the deep areas instead of towards the enamel areas, which all the other techniques produce.
Exactly.
Now, when we train doctors, we really want them to understand the why behind each of the techniques that they're employing. Because if you understand why you're doing what you're doing, you're not going to find the shortcuts, and you're going to be willing to take that extra 5 or 10 minutes to properly isolate, to properly layer, because the last thing you want to give up is the seal. And this is what we have focused on with our training programs, such as the Biomimetic Mastership, and also how my dad and his podcast has really started to outline the historical aspect of his journey going back from the mid 90s up till now to really try and change the profession for the better. And we are just so delighted to be with Dr. Romero and to truly call him a friend. You know, he's been out to Utah with us, done our 2-day hands-on training. He's also done the 12-month mastership, and he has exemplified this idea of, I am going to do what it takes to create the best results.
And reality is that with a few techniques, such as using the copper band, you can purchase this online. It's not something that costs a lot of money. One of the few things in dentistry, for $40, you have something that will last you for 12 years or 15 years.
So wherever you practice, you want something that has a thickness of around 0.125 millimeters, or if you're in the US, it's a different measuring unit for rolled out metal, which is in the mils, 5 mil. But we'll end these lectures with some videos of how we do a deep margin elevation. And so the first thing we're going to do is we're going to condition the smear layer through air abrasion.
This removes the smear layer and compacts the smear layer into the tubules, which reduces the amount of pulpal fluid coming into your bonding field.
So you can see that the Teflon's been packed, the rubber dam is in place, and I'm using a cut piece of copper that will be inserted between the real type matrix from Garrison. And you'll notice that as I'm pushing this with the hemostat, that there's very little distortion.
Mm-hmm.
Now, it doesn't matter if you put the copper in first and then stabilize it with a circular band, or put the circular band kind of loose initially and then kind of use that as a guide for the copper. I do that both ways. But you can see that the copper is resting on the Teflon and that it's past the margin. And that as I'm pushing with either a hemostat or a blunted instrument, we're creating some kind of blunt dissection with the copper.
Yep.
Now, for the record, this is the fastest copper I've ever placed, and I got it on video. And after I was done, I laughed with my assistant.
It's never this easy, but in this situation,
I've only recorded a copper twice, and you saw the other video earlier. And that whole video, we weren't breathing the whole time. We didn't know if we were going to be able to capture it. It's anytime you pull out copper, just plan on an extra 5 or 10 minutes in the dental chair.
And the most important thing is that you're taking your time. And that's what people have to understand. These things can take a little bit of time, but they're very, very rewarding once you get it to where you want it to
Yeah,
be.
when you got it where you want it, all of a sudden you have such greater, um, predictability with your adhesive success. And so once the bands are in place, then we follow our lesson 3 protocols of doing immediate dent and sealing. Here we're using a gold standard mild 2-step self-etch adhesive. So we're priming the dentin and enamel for 20 to 40 seconds before um, removing the solvent with a dedicated air syringe. Placing the adhesive. Now, if you're using SE Bond or SE Protect, it's important that you wick away any excess that accumulates next to the band because that will appear radiolucent on a radiograph. That could be mistaken as a gap or
Right.
recurrent
So
decay.
no puddles in the
No puddles.
Yep.
That being said, I did a tooth the other day. It was kind of a class 1, and I took the post-op radiograph. I'm like, oh, I didn't take a dry brush and wick away that. You can see this nice radiolucency right underneath the resin coat, which is our second step in lesson 3, which is a thin layer of flowable resin. And then as we do our deep margin elevation, we don't do this with simply flowable, but we use a packable composite that has a similar modulus of elasticity of um, intermediate dentin, which is right around 16 gigapascals. So this is APX from QRA. And I'm just blocking out the undercuts with these small balls of APX. This was restored with an indirect composite inlay. Here we're placing fiber over the outer caries on the distal axial wall. After the fiber is embedded into the APX, we take a small amount of adhesive and impregnate the fiber. And so depending on the size of the defect will really determine how many layers you need to do for your deep margin elevation. Sometimes a margin elevation is just a 0.5 millimeter of flowable. Other times it's 4 millimeters
of gingival like this one.
composite. So now I'm just taking a fine diamond. You could use a carbide burr to just remove some of the excess before taking your impression or your scan. And so here you can see what the pre-op x-ray was. We're right up against crestal bone. I was really, really pleased with how this turned out. This is now over a year old and it's doing great. And so that concludes
Deep margin elevation.
our lecture. Thank you so much, Mario.
No, thank you guys. I mean, I do want to just, a couple of comments before we end this today. But number one, the most important thing, uh, I want the dentists that are viewing this webinar to ask themselves, what kind of dentistry do you want to do? I love doing operative dentistry. I do a lot of direct restorative dentistry. I do a good number of indirects and onlays, but I do a lot of direct restorative. And I do it because throughout the years, I've developed skills that allow me to make teeth look like teeth, even molars and premolars. More importantly, when they have had significant breakage, through decay process. But that's just me. How do you see yourself? What do you want to do? How do you want to navigate through this career? I've been doing this for, like I said at the beginning, for 31 years, and I am enjoying dentistry more and more every day, just because I take my time and I try to put the best of me in every single case. Do I have failures? Of course I have failures. And that's why I like talking to clinicians, people that are out there doing the same things that I'm doing, because I'm sure that Davey and Dr. David also have had failures. That's part of what we do. But to minimize those failures throughout excellence is really the goal of every clinician. So, I personally learned a whole bunch, enjoy everything I've learned through the mastership. But not only that, I stay connected. I still chat and text with Dr. David and Dr. Davey and others that have already completed this mastership. I learn from their their excellent cases, and I also learn from their mistakes and from my own mistakes. Just to motivate you to find their YouTube channel, follow them on Instagram, try to connect with them. They're very reachable. They're easy to reach and easy to have a conversation with. I don't know if you guys have any final words before we close this today.
We're just really appreciative of all you've done, Mario. This was a great hour. I feel like the time just flew by. I feel like we were able to emphasize a lot of things that can help dentists wherever they practice. And I love that you mentioned that your preference is to do a lot of direct restorations, because there is a perception that a direct restoration is inferior. But when you really understand how to mitigate C-factor stresses and polymerization stress, there should be no difference in the longevity of a direct, a semi-direct restoration, or an indirect restoration. But even if your preferred method is indirect, guess what? You will always have a direct component to your indirect restoration, which is the biobase. And that often includes doing these deep margin elevations. And we hope that these tools have improved your enjoyment of dentistry. Now, we always joke with Mario that, he always cleans his rubber dam before he takes his photos. So if my rubber dams don't look as good as Mario's,
Well,
he's cheating just a little bit.
Well, Simone Della Peri puts a brand new rubber dam on every time he takes a photo for a journal. Simone cheats in a major way. But anyway.
So if your rubber dam rips when you're doing your caries excavation, don't feel bad. Just pack a little Teflon.
There you go.
The thing is, hey, that's why I always say, this is real dentistry.
Real dentistry.
I'm happy that we were able to have this chat today in the morning, and I hope that this will happen again in a couple of months. And thank you again one more time for taking the time from your busy schedule to be with me today in the morning. Have a great rest of your day.